Good afternoon, everyone. Understand your choices when it comes to gynecological surgeries. I'm Dr. Asya with you live from our official Facebook and YouTube social. Dr. Qasim was working with one of the leading hospitals of Kingdom of Saudi Arabia, where he has an extensive knowledge and expertise about laparoscopic surgeries. So Dr. Qasim, welcome for today's program about gynecology and laparoscopic surgeries.
Thank you, Dr. Asya.
So, my first question, Doctor, to you, I want my audience to know about your overall clinical journey when it comes to gynecology, obstetrics. You're being as consultant for more than 12 years. Something brief which can help our audience to know more about you.
Thank you very much, Doctor. Good afternoon, everyone. My name is Dr. Qasim Ahmed. I am from Syria. I studied medicine in Syria and graduated from Damascus University in 2003. After that, I got my residency also from Damascus University Hospital in obstetrics and gynecology, and I got Arab board degree in 2008. I worked before in Qatar and in Saudi Arabia, like you said, in a leading hospital in Saudi Arabia, and now I am in Dubai. In my previous experience, we did a lot of, we see a lot of patients, different kind. We did a lot of surgeries, 1,000 plus, a lot of deliveries. We deal with too many cases, high risk and low risk cases. And I hope that I will give benefit to this hospital and to the
Definitely
community.
Our patients will be benefited when there is a scope of expertise of more than 1,000 surgeries. Definitely it's going to benefit our patients. Doctor, let's start from basic because most of the patients, most of the people still are not aware about this laparoscope word. So I want to know from you, I want my audience to know what is laparoscope and what is laparoscopic surgeries in the field of gynecology and obstetrics.
Laparoscopic surgeries, it means minimal invasive surgery. That's mean from the word minimal, that's mean the patient will have minimal incisions, small incisions. She will have minimal complication, minimal side effects. Also, the recovery will be fast. So it is like it will do the same what open surgery did, but with better outcome and less complication and more benefit to the patient. It will use a camera and 2 or 3 other small holes to manage the surgery during the procedure. The healing after that will be faster. Patient will go back to her normal activity also faster. And most, I cannot tell you all, but most of gynecological surgeries can be done by laparoscopy.
Can be done by laparoscopy.
Yes.
So out of 100, how many will be able to done by laparoscopy?
Sorry?
If there is a scope of 100 surgeries for gynecology and obstetrics,
you can do of course, obstetrics surgeries like cesarean section. It cannot be done because this is have to be like open. But if you are speaking about gynecology, especially, yes, mostly all of them can be done by laparoscopy. Sometimes there is contraindications for laparoscopic surgeries. So that you can say like 90 to 95% of gynecologic surgery can be done laparoscopy. Even cancer surgeries also can be done by laparoscopy.
Absolutely, absolutely. I as a general practitioner, I generally see laparoscopic surgeries. Generally, people know about either appendix removal or either gallbladder removal. Patients are quite aware of those two procedures majorly.
Yeah.
But when it comes to gynecology, do you also feel that, doctor, now you're in UAE, you're in Dubai, before coming here, when people used to get back to you for the treatment, are they aware of this kind of thing, that gone are the days when we used to talk about open surgeries? Yeah. Now it's a world of laparoscopy. As you correctly said, less time, minimally invasive, and fit to work in some days.
Yeah.
So do you still face that overall people are still not very well acquainted with the knowledge of laparoscopy and the scope in the field of gynecology.
Yes, you're right. Because maybe the patients before, like you said, they don't know or we don't hear about it. But in the last few years, more patients now, they are aware and they are coming to ask especially for this. And since I came here, actually, we didn't do any open surgery. All of them are doing laparoscopy, and also most of the patients, they are asking for it. They are asking, they are coming asking for the service for fibroid, for ovarian cyst, for hysterectomy, for ovarian tumor, for pelvic floor repair. All of this can be done by laparoscopy and will save the patient. And the patients now, they are asking because now the more people are, they know already about the service and they are coming to ask about it. And they are asking about hospital that they have surgeons that they do this. And also we have a lot of surgeons doing this service now.
We are really blessed that we have Dr. Qasim here with us today. Yesterday, we had a very, critical case, I will say, and it was about a young girl. Without revealing of course, the identity of the patient, Doctor, I want you to explain that case which has come yesterday, and we could dealt very easily. And what do we expect when the patient?
This is
fast?
Also too much important and too much advanced to the laparoscopy. And some people maybe they will think that it cannot be done for young girls or for kids. We receive an 11 to 12 years old girl in an emergency situation with an ovarian cyst and ovarian torsion. That means the blood supply is stopped going to the ovary because the ovary is twisted from the cyst.
In a 12-year-old girl,
yes,
cyst,
she's also very small, very thin, but still can be done by laparoscopy. And the patient, she next day she can walk, she can move, pain relief immediately. And the surgery didn't take more than 30 minutes. So this is also one of the advances of the gynecological surgery. This patient, she has to go to school later. She will not feel anything when she goes back to her school. So, like I said, laparoscopic surgery, even for children, now it's available, and we also with all the scope of surgery.
On the other note, Doctor, there are many ladies who have already been diagnosed with cyst, chocolate cyst, or polycystic ovarian disease, or any other kind of cyst, broader term. And generally, they are following up with their doctors. And we generally recommend sometimes that, okay, we need to follow up, and it's not necessary that we will remove. We'll give the medicine. We'll see whether it is improving, not improving, and then decides. Overall, do you think that keeping cyst in the body when it comes to the fallopian tubes, or when it comes to ovaries, or that anywhere in the tract, do you think, what is your advice and actual advice, the real advice for that?
Actually, ovarian cyst has many kinds. There is functional cyst, there is endometriosis cyst, like you said, chocolate cyst, there is teratoma cyst, dermoid cyst, so hemorrhagic cyst. So dealing with the cyst, it depends on two things. The first thing, the size of the cyst, and the second thing is the symptoms of the patient. For example, endometriomas and dermoid cyst, you have to remove it because it will never go. But for functional cyst or hemorrhagic cyst, most of them will resolve spontaneously.
Doctor, what's functional and what is hemorrhagic?
Okay, the functional cyst is that the cyst being formed during the ovulation process, before ovulation or after ovulation. This we call it a functional cyst. It will be a clear cyst, just a wall with a clear fluid inside it. Hemorrhagic cyst is the same like functional cyst, but with bleeding. The bleeding will happen inside it, so we will call it hemorrhagic cyst. Both of them, mostly it will resolve spontaneously without any medication. Giving medication of a cyst will never resolve it. So there is no medicine to make the cyst go away. Mostly the cyst will go away by itself, no need for any intervention. But if you have an endometriosis, which would cause an endometriomas, which some people call it chocolate cyst, this will not go alone. You need to remove it, whatever its size is. And even if it's small, if you wait for it, by time it will be big. And also, endometriosis and the complication of pelvis pain, adhesion, and maybe sometimes infertility. And also the dermoid cyst, by time it will grow, and also you have to remove it. Dermoid cyst is something like came from the germ cell, and it will cause disturbance of the patient with pain, and it will grow like I told you. It will not, and sometimes it will be double side in the right or on the left side. So this cyst must be removed, and also it can be removed by laparoscopy.
So for all the audience, please listen to it very carefully, that if you are already diagnosed with any kind of cyst, there is no issue in taking second opinion from the expert, from the laparoscopic surgeon. Let it be, we will be very happy if you can get back to us. Dr. Qasim is there to reply to your queries. But anyways, it is your health, it's about you. Now, the other topic, what I have seen in my clinical practice is about endometriosis. That is the inflammation, or you can say swelling of the inner part of the uterus. And most of the women who come to OPD, who come to general practitioners, gynecologists, is about menstruation issues. So doctor, what is the scope of endometriosis or the swelling of the inner part of the uterus and the laparoscopy overall?
Okay. Actually, the endometriosis is a very wide.
I know, but
yes,
we can just simplify it for the audience.
Endometriosis could be giving spots of small endometrium growing on in the other parts of the body, not inside the uterus, because endometriosis is like the endometrium itself of the uterus, but it's growing in another part, not inside, not in the uterus. It may be in the ovary, in the pelvic wall. Sometimes also we can see it in the intestine or in the bladder. So there is a wide spectrum of endometriosis as a disease. Most of patients came complaining of pain, and sometimes we found, or often we can find also an ovarian cyst, which we call ovarian endometrioma or chocolate cyst. The rule of laparoscopy is to relieve the patient pain, make a diathermy, or to remove or excise this endometriosis focused lesion, or sometimes endometrioma, and it will improve the patient's chance to get pregnant later. So if the patient has infertility, or if she has pain, or if she has only ovarian cyst and she want to remove it, of course the surgery will relieve all of these symptoms, and it will give her a good result after the surgery. She will get benefits from, if she has pain, the pain will be released. If she has delayed pregnancy, her chance to get pregnant, it will be more better after the surgery. And also sometimes the endometriosis will cause adhesions in the pelvis, and this one you can also remove.
So the chances of infertility will increase if we.
Yes, there is a good percent of infertility related to.
Do you want to discuss any of the very difficult cases of endometriosis so far, or anything after the procedure actually they conceive and probably?
Yes, a lot of cases came with the history.
We would like to know,
sometimes they came with unexplained infertility. That's mean the patients did all the investigation and everything, and sometimes the ultrasound is not accurate, and then she came for diagnostic laparoscopy, and during the surgery, that's mean we go only to find out what's there. And then during the surgery, we found spots of endometriosis on the pelvis, making some adhesions. This when you remove it or you excise it, or also even you do only diathermy, patient maybe of 1 or 2 months after the surgery they get pregnant. So yes, the endometriosis has a big part as a cause of infertility in the female.
So we discussed about the cyst. We discussed about the scope of painful menstruation. We must take a second opinion if things are not going in the right direction. We also spoke a little about the infertility and unexplained infertility, where your doctor has said that everything is normal, but still you're not able to find out the reasons. There is the scope of laparoscopic gynecological surgeon who can actually tell you if there is anything beyond that. A lot of people who are really struggling for this unexplained infertility, reasons, I will suggest, I will urge them to please have a second opinion and relieve your mind. There's a world beyond our imagination. Science has really become better and for our ease only. One of the another topic I really want to know is the fibroid. Dr. Fibroid, I will leave that topic to you because fibroid is like, it's growing and it's really troubling women in terms of they are getting anemic, a lot of menstruation issues, painful menstruation, bleeding, and, and eventually a lot of health issues. So I'll leave up to you that how we manage fibroid through laparoscopic surgeries.
Actually, yes, uterine fibroid is now becoming more common, and we are seeing it more than before, especially sometimes in young ages. Actually, if the fibroid treatment of the fibroid depends on the patient's symptoms and also age. The definite treatment of fibroid is by hysterectomy. That's mean removing all the uterus. But this one also cannot be done if the patient is young and she still wants to get pregnant. So if the patient completed her family and she don't want any extra kids, and she is above 40 and doesn't want to keep the uterus, so we can do laparoscopy and remove the uterus with the fibroids. So she will guarantee the fibroid will not come back, and also she will get relief from all the symptoms. And the other way to remove the fibroids is the myomectomy, which is removing only the uterine fibroid. And this also can be done by laparoscopy up to like 10 to 12 centimeters of the fibroid. But if the fibroid grows more, sometimes we remove a fibroid to 30 centimeters.
30 centimeters?
Yes, 3 kg of, it's a big mass inside that. So this one cannot be removed by laparoscopy because this mass will be filling all the abdomen. So there is no space for you to, so you have to open. But still, also we are trying to do it with a smaller incision as we can. Even the fibroid is big, we are trying to remove it and in pieces, so we will not open like a big incision. The first thing will go to the mind of any patients that, okay, 30 centimeter fibroid, so I have to make a 30 centimeter incision. No, that's not correct. Even within 10 centimeter to 12 centimeter, we can remove it, but it will take time, and there is a technique that we can remove it without making the incision big. But if the fibroid is below 12 centimeters, 13, 14, it's around like this, according to the situation during the, because we go in the laparoscope and we will see if there is a chance to remove it by laparoscopy. Yes, we remove it, and after that we morcellate it. We, of course, we take it in pieces because it's a solid part, and we are taking it in pieces. Usually patients with fibroids have two complaints, even heavy period and then anemia, and sometimes recurrent blood transfusion or taking iron to replace what she lost from her bleeding, or she has pain or urinary or symptoms that it's bothered her and she wants to remove this fibroid. And sometimes also fibroids will be without any symptoms. If it is a small or medium size and doesn't cause any problem to the patient, so and she can live with it and it's not growing, she only has to follow up this fibroid without removing because it's rarely become something malignant. Mostly the fibroid, it's a benign disease. And like I told you, if the patient doesn't have any symptoms, the fibroid is stable in size, not growing, and it's small, and the patient doesn't complain of anything, she can leave it alone. She doesn't have to do anything with it. But if she starts complaining of bleeding, pain, the fibroid is growing, of course, she has to remove it. And I advise that if the fibroid is growing, to remove it before it's become more than 10 to 12 centimeters, because this is the chance to remove it by laparoscopy and to get all the benefit of getting well soon. And like I told you, all the complication will be less, the recovery will be faster, or even staying in the hospital is less.
So, Doctor, one of the biggest myth, I will say, unmarried girls with fibroid and big fibroids.
Yeah.
So I really want to know the exact situation. So how do we deal with that? Suppose it's an unmarried girl and size of the fibroid is big.
Yeah.
How will you deal with it?
Like I told you, if the patient doesn't have any complaint, the size is accepted, not too much big, like it's not over 13 or 14, and the patient doesn't have a complaint. We don't prefer to make incision with the uterus and the patient doesn't have kids and she's small and not married. But if there is a symptoms, if there is a bleeding, if there is pain, if the size is big, we don't want later to grow more and then we will have to do open surgery. So we still can remove it by laparoscopy. One of the challenge cases I faced, as long you have said that about unmarried patients, because when we say fibroid, most of us, we know that fibroid is growing only on the uterus. But I have one case before for a like 30 years or 29 years old patient with a fibroid in the vagina, and she is unmarried. And she visited many doctors, and they said that they have to do it transvaginally because they cannot do it from up. It is in the vagina, and it's big, and it's all of these things. And she don't want to do it because she's a virgin, not married. She don't want to go to do any vaginal procedure. And she came to me, and I checked the case, and we did the whole investigation for her. And I told her that I will try to remove it from the abdomen, but of course not by laparoscopy because the laparoscope will not reach the vagina. And yes, we do it by a small incision, like a smaller than also the caesarean section, and we remove the fibroid from the vagina without affecting, the virginity of the patient from the abdomen. And it was also a case report that time because not done before. But the patient was very happy because, if she is not married, she is worried like she would do a vaginal procedure. So fibroids can grow also in the ovary. We removed also, maybe yesterday, we removed one ovarian fibroid. It was like a mass in the ovary, and we found out that it is an ovarian fibroid. It is rarely happen. Mostly it will be on the uterus, but we see it also outside the uterus.
Absolutely. When I'm talking to you, I feel like there is so much to know for general practitioners, for other doctors to know, so that actually we drive our patients. We are, responsible enough to drive it to the, right surgeon. I'm so happy that I am listening from you. I am gaining knowledge, and I'm hoping that a lot of patients are also getting knowledge by this thing. That it is whenever there is a health issue, whether it's cyst, whether it's fibroid, whether it's any menstruation issue, don't just leave it and say that, okay, I'm going to take the medicine and I don't want to go into the surgeries. Surgeries are no more difficult, but it's going to save your life. The more we delay, the more is an issue to your health. As Dr. rightly said, that we delay things and then we finally land up into open big surgeries. So let's at least from these kind of programs or any other similar programs get benefited and get back to your doctors and actually get a proper treatment about that. On that note, I want to know from doctor that what is the biggest, in terms of kgs, the fibroid removal you have done so far? Because
like I told you, we remove one fibroid. I remember patients came to the emergency room where she cannot pass urine. She cannot go to and she don't know. I think she thought that she is fat or increasing in weight. I don't understand, but actually she is like more than 9 months pregnant. Her abdomen was full with a mass inside it. And when we do the scan, she has a 31 or 32 centimeter fibroid. It came like 3 kg after
3 kg.
Yeah, 3 kilograms, like a baby. And we planned her for a surgery, and we did it. And it also the patient will get too much benefit from it, but of course cannot be done by laparoscopy in this case because it's a huge.
My question was about the biggest size of fibroid you have removed. So
yeah,
far.
This is the one. This is the biggest one, 30 centimeters.
And what was the age of the patient, doctor?
She was 30 plus, and she was married. She has kids also. Yeah.
Okay, doctor. My next question is about the urinary incontinence in women.
Yeah.
A lot of cases, we generally, I personally see as a general practitioner, a woman, after 40s, 50s, even at least 2 to 3 women among 10 have this kind of health issues where urinary continence, that means they're not able to retain urine, they'll have to, one or the other way they are traveling, even if they cough or they sneeze, they pass little amount of urine. And generally, we have seen an association with something related to the uterus. What is your thought process on that? And is there any scope, because you are an expertise in urinary incontinence as well? So what patients should know, and who are the patients who should seek an opinion from you if they are traveling with this kind of issues?
Urinary incontinence have two or three, you can divide it in three terms, that there is urge incontinence, and there is stress incontinence, and there is mixed incontinence.
Absolutely.
The most one related to surgery or to our part is the one is with the stress incontinence, which that means that the patient cannot hold the urine if she sneeze, or if she cough, or if she hold heavy things. Sometimes she will pass the urine. Even during laughing, maybe she will pass urine and she cannot control it. And this kind of incontinence, it's caused by the weakness in the pelvis floor muscles. And here will come the role of the surgery, and also it's minimally invasive surgery. It's not by laparoscopy, it's like the small holes from down to make a slit. We will put a mesh with 2 holes down. All the operation will take less than 15 minutes to alleviate the bladder neck, and then to help the patient during any extra effort, abdominal pressure like coughing or sneezing or laughing. It will help her not to release the urine. For the urge incontinence, it's also one of the common problem in women, but this one can be treated medically. The patient will not leak urine during coughing or this. No, the patient will complain that she is always feeling that she has to go to the bathroom, and when she went there, she doesn't pass a lot of urine. So always she has this feeling that she has to go to the bathroom, but even her bladder is not full. This is because of the overactivity of the bladder. This is something can be treated medically, and most patients will get benefit from medical treatment.
Inshallah, definitely.
And the next one, that the patient have both together. That means that she need to take the medication, and maybe sometimes she needs the surgery. Stress incontinence also, there is some exercise. We teach the patient how to do it, and if she did not get benefit from the exercise, the next step will be the correction surgery.
Another very important sensitive topic, though we talked already about it, but I want my patients to know little details about is the infertility, unexplained infertility. If couple wants to seek advice, what is the approach towards the doctor? What will they expect from you? And how do we achieve the results?
Yeah. You cannot say for any patient that you have unexplained infertility until you will do all the investigation.
That's what I'm saying, doctor. They have already. I'll repeat my question. They have already gone to all the doctors, gynecologists, general practitioners, did all the tests, and still there is no reason.
If there is no reason, of course, if she did all the investigation for her and for her husband, and all the results are normal, then she has 2 options. This is also according to her age and how fast she want to get pregnant. If she's still young, she's still one of her options. And I have received a lot of patients from IVF centers with unexplained infertility and sometimes failed IVF to do diagnostic hysteroscopy or laparoscopy, which also the diagnostic hysteroscopy is also a minimally invasive with a camera inside the uterus to check the uterus and the opening of the uterus to see if there is any problem there. And the diagnostic laparoscopy, like I told you, sometimes we will discover small cysts, sometimes adhesions, sometimes endometriosis, and sometimes we didn't find anything. So still, sometimes we reach that we cannot find the reason, but sometimes we can find some reason that it cannot be discovered with other investigation. And by treating this thing, patient will get pregnant. So it will increase the chance of the patient to get pregnant if you treat it, if you find something.
Absolutely. I think the session will be endless because there are so many questions. But doctor, overall, how to raise the awareness about minimally invasive surgeries when it comes to gynecology and obstetrics?
like I told you, the awareness before it was very low. Now more patients became aware. I think most of the patients now start hearing about this option in the surgery. But yeah, like you said, maybe some patients, they don't know. They went to the surgeons and still they are choosing to do the open surgery. It's fine to do open surgery, but like I told you, the laparoscopic surgery is better, more advanced, more good to the patients. And raising the awareness, it needs like these sessions from other hospitals, also from other gynecological laparoscopic surgeons, like to just give the patients the right information, what is this surgery and how to ask about it and when to ask about it, and to know that their cases then can be done by laparoscopy.
Absolutely, doctor. So all the audience who are listening to us, whether it is cyst, whether it is fibroid, whether it is problems related to menstruation, whether it is infertility, whether it is just the urgent incontinence or urinary incontinence, you're not able to hold the urine, please seek advice from the specialist, and we are always there to help you. You can always book an appointment with Dr. Qasim, or you can also email us on myprime@primehealth.e. The details will be available on the page, on the desktop page, on the screen. You can note down that, and we will certainly get back to you. In the meantime, we have received certain questions from the audience. Ms. Sunita is asking, good afternoon, doctor. I have a friend in her early 50s. So she's asking on behalf of her friend. She's 50s who's still suffering from dysmenorrhea and grade 4 endometriosis. Will the laparoscopic hysterectomy be the right choice of surgical removal for this grade?
Yes. Patient early 50s with dysmenorrhea and pain and grade 4 endometriosis. The best option for her is to do the total hysterectomy with bilateral salpingioophorectomy. She is over 50 already. She has to remove both ovaries with tube, with the uterus. This will decrease the pain a lot, and some of them will not have any pain at all.
If she will not opt for the surgery, doctor, then what will happen?
She will still suffer the same pain.
But she's already in 50s.
She has to wait until she will be like, no one can guess. Maybe some people will be menopause on 55, some people on 54, 53. So she can wait, but if she want to get rid of this, she can. It's better for her to remove. And she never guess what will happen after that, if she's gonna have another problem. So this will solve problem, and also any other future problem will not happen. So if she's suffering from pain, dysmenorrhea, and she cannot tolerate painkillers not relieving her, I don't prefer her to receive any medication. It's better for her to go for surgery.
Absolutely, doctor. Doctor, just one question also came to my mind, because I don't want to miss that important topic, is that high-risk pregnancies.
Yes.
Is there a specific thing we need to look into it? First of all, who are high-risk pregnancies, and what should be the different approach for them?
Of course, the high-risk pregnancies, that means that the pregnancy is accompanied by any extra medical condition with the patient or extra problem in the baby itself. So the high risk, there is two parts related to the mother or related to the fetus. High risk pregnancies related to the mother, that any patients with any chronic condition, or she has any problem that she's receiving any medication during pregnancy, this is a high risk pregnancy. Related to the fetus, also any cases like multiple pregnancies, IVF pregnancies, you can call it like a patient with history of recurrent abortions. This is all high-risk pregnancies, and there you have to deal with them. Especially patient with any history of congenital anomaly, she will know that if she has another anomaly. So there is like a wide spectrum of high-risk pregnancies. That means that patient's pregnancy is not straightforward. Sickle cell disease, diabetes patient, hypertension, antiphospholipid syndrome. A lot of cases, like I told you, a patient with multiple fibroid, she has many fibroids and she wants patient with recurrent mid-trimester abortion, for example, with recurrent also first trimester abortion. All of this need special care, need special investigation during the pregnancy, and sometimes we need to do some procedures to during the pregnancies for diagnosis or for treatment. So this is why we call this one high-risk pregnancy, and there is also some extra medicine. We are arguing the rate of the antenatal visit is different, and the time also is different. What you need during pregnancy for her and for baby care also different. Investigation is different from the straightforward or non-complicated pregnancy.
It gives really me, and I'm repeatedly saying that today I'm also empowered with a lot of health education awareness about the scope of laparoscopy. So I will request every woman who's suffering from all these diseases not to take your health or life, on a least priority. Get back to us. We are there to help you. You can. If you want to book an appointment with doctor for clinical advice or opinion, we are there. You can. The number is on the screen, and you can book an appointment through that number. Also, you can email us at any point of time, not today, tomorrow, anytime. Please save this email address is myprime@primehealth.ae, is exclusively for our patients. We will definitely get back to you. Before winding the whole session, I would like to take away message from our speaker. Dr. First of all, it was really an honor to share the same platform, and I wish and I hope that we're going to continue this session on different topics, maybe one particular topic, and the whole journey can be discussed.
Yes.
Thank you so much, Doctor, for that. So what is your advice for our audience overall?
Thank you very much, first of all, and I am grateful that I have this chance to speak with the patients and with the audience to hear about these topics. My advice to the patient simply to raise their awareness, to listen to these videos all the time, just like to improve their awareness about what's new in the medicine and what's new in the treatment of all in gynecology or other medical problem. And I hope that all they get benefits from this session, and inshallah in the future we will have extra sessions about specific, and any of them, if they have any specific concern about some disease or treatment or something in obstetrics or gynecology, I hope that they will suggest this in the comment, and maybe it will be our next session later.
Inshallah. Thank you very much, everybody, for joining us, and thank you for listening us. We're going to have shortly, in some days, other session with Dr. Qasim in Arabic language for all our Arabic audience. Thank you so much. Have a nice day. Stay blessed. Stay blessed.
Thank you.